Welcome to the AHPs and Quality Improvement podcast, where we are on a mission to raise the curiosity and profile of allied health professionals in quality improvement. We will be delving into the very heart of what quality improvement means. We will be contemplating the power of networks and spotlighting great QI work that is happening in the AHP world. We will be looking outside of the AHP world to see who we can learn from and apply this to our day-to-day work. Likewise, you don't have to be an AHP to listen. Our best work is done in collaboration, and we want to harness the power of connection to improve the care we offer patients, the teams, and the systems we work in. Hello listeners, I'm Jo Kitchen, the network facilitator and host for this episode. Today I'm really delighted to have Divya Narasimhan here with me. Divya has been carrying out some great QI work around the access to pulmonary rehab, and she's been using some interesting QI methods to look at what is currently happening and how we can address this. So my first question is about the use of QI methods to look at improving health inequalities. So why did you choose this sort of approach? Don't we already have an idea of what the gold standard pulmonary rehab service is, and couldn't we just roll that out?
Okay, to me, QI is more about a way of thinking rather than having a system or a rigid guidance to follow. Right. So yes, QI gives you a system to follow, a way of thinking, more of it, rather than, a lot of people do say that QI can be really slow. Now, I would say it is slow to start off with because we spend a lot of time to understand what the problem is. And it's similar to, I was thinking about an example. It's like if you have a car broken down and if a roadside assistant comes to fix the car, the first thing they'll have to do is the diagnostics. They need their tools to diagnose what is wrong with your car. They will ask you questions on what the problem is, because if they don't understand the problem, they won't be able to fix the car. It's a similar kind of approach is what QI gives you as well. Spend a lot of time to understand what the actual problem is. And once you have figured out what the problem is, it's easier or it's faster to be rolled out. Right? Now, coming to the gold standard, when it comes to health inequalities, we were very much aware that one size does not fit all. Now, people in the disadvantaged group who have got difficulty in accessing the service itself, we don't know whether gold standard was the right way to actually put it out. But we were very keen to try it as gold standard PR. We want to offer them the gold standard PR, nothing less than that. But at the same time, we don't know what changes that needs to happen for us to offer this PR. So this is where QI comes in. I think it is a how. How do we offer pulmonary rehabilitation, a gold standard pulmonary rehabilitation to these people who are disadvantaged?
That's really interesting. And what you're saying at the beginning about the process being slow to start off with, because you're taking the time to really examine what's going on, to consider the problems, and to reach out to different groups of people rather than just assuming that we as the healthcare professionals know best all the time when we haven't got the experiences of all these different groups. That's really interesting. Are you able to tell us a bit more about how you planned your project? And just for our listeners as well, what pulmonary rehab is?
So pulmonary rehabilitation is simply a group exercise and educational program specifically designed for people who have got a confirmed diagnosis of a long-term lung condition. So it could be COPD, it could be asthma, it could be bronchiectasis, it could be other restrictive lung conditions like fibrosis and so on. Now, if someone feels that their symptoms, such as their breathlessness, is interfering with their day-to-day activities, please go speak to your GP, your practice nurse, or your respiratory consultants, or just Google search for pulmonary rehabilitation in your borough. Most likely your local NHS service will have the details online. Do contact the pulmonary rehab service and find out if you will be eligible for it. The sessions are led by experienced physiotherapist who knows how to deal with breathlessness, anxiety, and panic attack. And also pulmonary rehab is evidence-based. It is known to improve quality of life, known to improve your physical ability to do something. That's your exercise tolerance as well. Coming to the how did we plan? Health inequality, as you know, is a huge topic. It's not something simple. It's not straightforward. So the first thing I think we did was to get the local knowledge. So we spoke to the actual pulmonary rehabilitation team to understand what do they think are the health inequalities from their experience of working in the borough. And we ticked that off to start off with. And then later we looked into the research and evidence to clarify whether what we heard from our professionals is right. So, for example, we do know that 2 of our boroughs have got huge areas of deprivation. And by research, we do know that deprivation has high amount of smoking and also connected to high drug usage as well, which means there's highly likely to be a lung condition. And 2 of our boroughs do have high number of homelessness as well and substance misuse as well. So we used research next to first confirm whether there's going to be high level of lung condition in these cohorts that they're mentioning, and then look into research of why have these people have difficulty in accessing these services. What does other people have already found out? What has other people have already done? What has worked? What hasn't worked? Which gave us an idea about the direction in which we are going. Just to give you an example, when we looked at a paper about substance misuse, it clearly said to us that that cohort of patients do not engage very well with primary care or secondary care, but they engage well with specialized addiction service. And if you actually think about it, traditionally pulmonary rehab, we only receive referrals from GPs, secondary care, tertiary care, maybe some of the specialist physical health community services, but we don't give access to mental health services at all. But very much these services need to have access to these pulmonary rehab referrals. We're missing out a huge chunk of patients who do not engage with primary care, but engage with these specialized community services like addiction service and homelessness. So these were all the learnings that we got from the research. And then we went and met the teams, the stakeholders, engaged with them, who were all absolutely super excited about a respiratory team coming into them. And then we engaged with both the side of parties, the pulmonary rehabilitation team and the addiction service. We have a lot of people with lived experience working within the addiction service. We utilized them to understand why do people not engage, what is the issues with access. So a lot of question and answer, a lot of surveys, focus groups to actually understand the depth of the problem, which is where the time was spent. A lot of time was spent there. And once we got that done, we know what the next step was. We need to give access to addiction service. We need to remove the extra steps in between to get us referred in. We understand a few things around familiar venues. So these patients, a lot of patients who will have addiction issues do not attend clinics in hospital setting or in that community hall where pulmonary rehabilitation is usually run. That is not their familiar venue. That church hall that we utilize to conduct pulmonary rehabilitation is not this cohort's familiar venue. So it's about understanding what is their familiar venue and trying to take the service to them.
That sounds really quite exciting, because you found a whole cohort of unmet need there. Was that what you were expecting to find before you started this? Because I know that you discussed finding the research there, but it seems that maybe you had some ideas and then had to adapt.
When we looked at the research, we do know there is a huge cohort in this of COPDs, highly and asthmatics within substance misuse and homelessness population as well, because it's all interconnected. One leads to other as well, substance misuse and homelessness. So we did expect a huge cohort of patients, but what happened was when we went in, even though there was a great enthusiasm, we did not get many referrals in, which was a shocker. We were like, what? We should be receiving a lot of referrals. We were expecting to be swarmed by referrals, but we did not. And again, it's that question about why is that? And the things that came up is because the cohort of patients that we're dealing with do have complex physical and mental health condition. So not necessarily everyone is suitable for pulmonary rehabilitation because of that. A lot of people do have negative experience with healthcare from the way they've been treated before. Trust on healthcare is really low, so we really have to work on that. So we were not swarmed by referrals, which was a shocker. That is something we did not expect. But in other way, I'm turning it positively as well, because a lot of services that we have spoken to about providing pulmonary rehabilitation to these cohort of patients have always kind of stepped back to say, oh no, we don't want too many referrals from them. We are already inundated with referrals. This is going to increase our caseload. And then very positively, I say to them, no, that will not happen. You will not be swarmed by referrals from this cohort of patients. We get an average 4 to 5 referrals from here a month. And that is what it is going to be. You will not swarm, but that 4 or 5 patients are those who have never been offered pulmonary rehabilitation before. And so we are providing that opportunity to them. So in a positive way, it is great that we are not getting swarmed by referrals. So services feel comfortable to step into and provide access to these patients.
That definitely sounds like it's more manageable from the point of view of being able to run these services and not have a sudden surge. But then also you have this treatment. If we could put pulmonary rehab as a pill, we have this thing that is able to make a huge difference to people's lives. And if those 4 or 5 extra people a month are able to get the benefits and access to a service that they wouldn't have known about, or the people they were in contact with maybe wouldn't have known about to be able to refer on, that does make a huge difference.
Yeah, just to give you some data on top of my head is it's like around 20 months since we started this pilot. And I think around 86% of people who have been referred so far have been offered pulmonary rehab or been referred pulmonary rehab for the very first time, which is a huge percentage, isn't it? So
Yeah.
these ones never knew about pulmonary rehab, never knew something like this existed.
That's huge. While you're doing this project, did you use any specific quality improvement methods?
I am trained in IHI, PDSA cycle quality improvement method. So that is how my brain works. Even though recently, one of the other trusts that I work with, they use A3, which is lean. So I have attended that training, but I haven't fully utilized it. But again, like I said, it is more of a way of thinking that has given me another way of thinking where I'm stuck, where it's needed. But predominantly, it will be the PDSA cycle is what I normally use.
And they are such a straightforward tool, aren't they? But to do it well, to, as you said, get that planning stage right before you even think about doing something, and to set up the tools to be able to measure the impact straight from the beginning, it still takes quite a lot to do the PDSA cycles well.
Absolutely, absolutely. Yeah, but I don't want the listeners to be put off by different terminology of PDSAs and so on. That's why I keep saying it's a way of thinking. A lot of people do think in that way. I think as AHPs, we all have that curious mind, and we all adapt quite quickly to changes as well. We all have that passion to make a difference to our patients. We all do. So this QI is just giving you those tools to get the thinking right in a steamed way, I think.
Absolutely, to bring that curiosity out. And
Yeah.
I think we in different conversations with people, we do keep coming back to that characteristic of an improver, of being curious, of asking the questions like, who else could we be reaching? Why isn't this working? And then asking those why questions time and time again. In your work, you did some collaboration with Arsenal Football Club. So how did that come about, and why did you work with them?
Okay. Now, why did it come about is because of that familiar venue that I told you in the beginning. So the cohort of patients that we are working with, the inclusion health group, which includes substance misuse, homeless, we will soon be stepping into sex workers and so on as well. So we need to be offering them pulmonary rehabilitation in their familiar venue. So where is this familiar venue for this cohort of patients is what we started to look into. We wanted a space which is suitable for pulmonary rehab, large enough for pulmonary rehab, easy for people to access it, so there is good transport link as well, and it is spacious, airy, all those things that we would look for in pulmonary rehab. And this is where Arsenal comes in. So Arsenal is a familiar venue to the community, right? And they were able to offer us a space there. Now, for all Premier League football clubs, apparently do have a community arm, and they all run one something or the other to improve the health and well-being of the community. And if you think about it, that is what we NHS are there for as well, in a way. We are there to serve our community, to improve the health and well-being of the community. It more or less, we both have similar aim. Well, we're two different sectors, but we have similar aim, working towards the well-being of our community. And it kind of felt like, okay, it's a familiar venue for the patients. We have similar aim. They're able to offer us the space. It meets their community needs as well. It ticks our boxes as well. So it's like, why not? And it also serves as an incentive for our patients as well. We are in the Arsenal Stadium. We have even an Arsenal coach who comes in and provides the exercise session. Yeah, and they are really good as well. Around Christmas time, they offer free stadium tour for the community. And we say to our patients, if you're regular, if you attend, we could put your name. And last Christmas, yeah, we had 4 or 5 patients went and did a free stadium tour as well. So they were, I think, in a way, it's all a bonus, which encourages people to attend these sessions as well. So yeah, and that's how it all got in.
That sounds really fun as well. And I think part of encouraging access to different communities and groups is the motivation. And it's not necessarily monetary incentives, but that community feel. It's places that people know, and maybe have a more positive association with, rather than in the past we might have tried to host these in hospitals or in more healthcare settings. And having a coach come along, that sounds brilliant as well,
Yeah,
and lead some of the sessions.
absolutely. And there is one more thing as well is what we found out is we wanted to declinicalize the service that we provide to this cohort of patients. And I think Arsenal actually does that really well as well. So it is not in a clinical setting, it is in a football setting. And so it kind of doesn't feel like you're attending a NHSE service. which also helps. And I think they are able to as well, because they don't have the health hat on them, they're also able to access the community much better. We have also worked with Tottenham Football Club, and they do some fantastic job in the most deprived parts of Haringey, which there are lots of lessons to learn from them on how to reach the hearts of the deprived area for us in the health sector. So yeah, I think there's a lot of learning to do as well from these football clubs.
Yeah, so out of that collaboration, actually, for you and your team comes a whole amount of positive learning as well.
Absolutely.
In some services, the question like what matters to me keeps coming up as a question that we might ask patients. But also, I think when working in collaboration, you talked about the shared purpose between the football club and then the health services. Well, the health of the communities we're in matters to both. So we've got that commonality there to plan services together and really get some effective work going.
Absolutely.
So we've been having some conversations about failure in the quality improvement work. So when we set out to do a project and maybe it doesn't have the improvement that we've hoped for, and I was wondering if there are any points in your project that haven't gone to plan, and how did you manage this?
The way I see it is, if a project has failed, we have learned how not to do something or what does not work, which is again a success, which is again a victory, that we have learned something how not to do, isn't it?
Yeah, so true.
And also, the project did not go to my plan. I did not get the result I wanted to do. The way I see it is, it is like I had an assumption. I thought this is how it is going to go. Gosh, but it has proved me wrong. It is totally the other way. Or this is not what the patients actually wanted. So as a healthcare professional, to me, it is changing my perspective about service users, what they want, what they need, how they want it. Or it's not just the service users, anything. Your project could be something to do with the staff as well. So yeah, anyone. So I think you don't have to class yourself as a failure, a failed project. You have learned something out of it. In our projects, we have faced so many of it. So many, like I said to you, we thought we are going to be swamped by referrals, but we are not. Okay, so what do we do next? There was a huge enthusiasm when we went into the team, the substance misuse team and the homeless team. But why are we getting only 4 or 5 referrals? Is there anything more we need to do other than from the patient point of view? Then we realized we have to do a lot of work with the key workers and the housing navigators, who are the key people, if you like. They work so closely with these patients. And then so I thought there was a lot of enthusiasm and there's going to be referrals come in. I did a couple of training sessions. They know what pulmonary rehabilitation is. I'm going to get the referrals. No, you're not going to. You have to continuously work with them. That is one staff area where there is huge turnover as well. So you'll have to do constant presentation, in-service training. We invite them to come and attend pulmonary rehabilitation service or the sessions, meet their patients. So it's a continuous cycle there. Incentives was one thing we were told that it will absolutely work. If you provide incentives, the likelihood is the cohort of patients is going to engage with you. They will attend for the session because they're getting something out of it. We found it doesn't work for pulmonary rehabilitation. It did not improve engagement. There are a lot of failures we have had as well, but they were all good learning for us to say, again, what does not work or how one has to move forward.
I think it goes back to what you said at the beginning about the QI being a way of thinking and a way of approach rather than a series of steps that you just follow and expect a success at the end. But I think it does also take some humility as a leader to be able to talk about the things that haven't gone so well. And it's ever so helpful to learn from your experiences. So thank you for sharing that. What has been the impact of your project so far? I know it is just a pilot at the moment, but I think you have been gathering some data. And so what do you see as being the impact so far?
Like I said to you, we have got more people referred into the pulmonary rehab service who have never been offered pulmonary rehabilitation before. I think that is one huge step. We have managed to engage. So in pulmonary rehabilitation, after referral, we have something called as initial assessment. We have had a huge, again, a big percentage, on top of my head, I don't remember it, but a big percentage of patients managed to attend the initial assessment, which again is a huge success for us. So when they attend initial assessment, what we actually try to do is to provide a holistic respiratory assessment, which is what all pulmonary rehabilitation services do. But in this case, we will have to keep the assessment very short as well, because we do find this cohort of patients concentration is not great. They will want to leave very soon. So usual pulmonary rehab assessment takes about an hour. We try and cover as much as possible within half an hour. But we try and provide a holistic, check their inhaler techniques, check their symptoms, try and give them advice where possible, because we don't know whether this patient is going to turn up the next time or not. So we try and check as much as possible during the first session of it. And we have had people who attend the pulmonary rehabilitation sessions week after week, 2 sessions every week, have given us great testimonials saying that it has reduced boredom. People have said that it has given them the structure. The days when they're out to do pulmonary rehabilitation, they're actually not thinking about smoking, because that 2 hours they're with us, they're not smoking. I think they are all good impacts as well. The other side of things are during the process, we also identified that the first step of actual diagnostics, the access into diagnostics is poor as well for them. Because they'll have to go into a hospital setting to be diagnosed, or into that clinical setting to be diagnosed as well. So the diagnostics is poor as well, access into diagnostics. So we actually did 3 days of diagnostic sessions at the Arsenal Football Club just for this cohort of patients. We had around 80 people turn up just from this cohort. We have a lot of people diagnosed, some were sent for further investigations and so on, so we understand we have to improve access into diagnostics as well. And then coming to the entire respiratory care pathway, pulmonary rehabilitation is a part of it. So we have now managed to set up a respiratory nurse-led clinic within our addiction center, which can be accessed by addiction and the homeless population. And so they are in that pipeline of COPD treatment plan. We currently also have the tobacco dependency treatment come into a substance misuse, offering their service as well. So I think the learning has been shared in different places. And so now we kind of feel that we have put a respiratory pathway, even though it's not everything totally in place. Some of the access to diagnostics, the spirometry clinic, we are very much aware, the commissioners are very much aware something needs to be done for this. At least we brought that awareness through this project. We have started a respiratory nurse clinic. Tobacco dependency is coming here. Last flu season, we contacted the vaccination team, and we actually set up a clinic within the addiction center. Usually they have a mobile van. They drive to different places, the vaccination team, to offer vaccines, but they don't visit the addiction center. So we managed to get them in last flu season as well. So it's kind of having a holistic respiratory approach. I think that is the huge thing here that we have achieved.
That is quite considerable, from looking at the questions about why again, and then unearthing that you need to also be able to providing diagnostics to these groups as well, because people aren't going to refer them if they don't have a diagnosis. So yeah, looking at along the whole pathway as well, and that looks really exciting there. And I think you've kind of already told me about the next steps for this project. Is there anything else you wanted to mention?
I think, like I said earlier, we are looking into the other areas of inclusion health group. So sex workers and people facing criminal justice are on the card. We are just starting scoping work around there to see what we can do around it. We're also doing some scoping work around mental health. Again, they are co-occurring cases. One leads to other. So we're kind of looking into that as well to see how that can be offered. And obviously, this project was carried out in Islington, and we have other boroughs within our ICB. So we have now shared a learning to other boroughs, and other 3 boroughs are actually working on it. We have one that has actually opened up, started accepting referrals from homeless and their local substance misuse service. There is another service who are working very closely with them, and they're planning to provide a cohort very soon. And we have another service who is doing it as a whole project by themselves, but taking all our learning and implementing it. So it looks like all the teams will have inclusion health group pulmonary rehabilitation, which is a huge success. And it's not just inclusion health. We do have a lot of cultural aspects as well within North Central London, but that we are looking into. So that is something we are concentrating. So this year we will be concentrating more on the cultural aspects and see how we can improve access and make our pulmonary rehabilitation service more culturally sensitive, and bring more ethnic minority people into it as well. That will be the next one.
There's plenty of work there to keep you busy, isn't there?
Absolutely.
So thinking about health inequalities, we've become more aware of the importance of tackling these. As you've highlighted, there's just groups of people who don't have the same access to services, but there is still a long way to go. From your experience, what is key to tackling health inequalities?
What I found out is, after being nearly 2 years in this post now, there's so much work going on health inequalities, so much. The ICBs are doing health inequality work. Local councils have got health inequality work going on. There's a lot of charity and voluntary organizations doing health inequality work. We as NHS are doing health inequality work. So there's so much going on. But kind of feel everyone is working silo. Everyone is reinventing the wheel again and again, which is such a shame, because it is a huge topic and it really needs a collaborative approach, a system-wide approach to tackle this huge problem, to even understand the huge problem. So I think when it comes to the key thing, I really think we should encourage everyone to share their learning, whether it's success or failure, it does not matter. Learning is learning. The more we share, the easier it gets for someone else is going to look at the project again. We are not going to start from the scratch again, because there's so much data people are holding, and you kind of go in circles looking for this data and then find out someone has already looked into it, analyzed it, and have got a report on it. And you're like, shocker, I could just use that rather than me trying to do the whole thing again. Yeah, it will be nice to have a forum somewhere, probably. It will be nice to a place where all health and equality work is being held, and we could just, whether it's a local council that holds it or whether it's the ICB that holds it, I think that is the way forward to make things easier for everyone.
That's so true what you say about working across systems, because I'm thinking about the work we're trying to do in sharing and promoting good practice with quality improvement. And we're a little bit in our healthcare bubble, and we have sites like Fab NHS stuff, which is absolutely brilliant for sharing case studies, and we're starting to use that more and more, and that's great. But we also need to be working with local councils, with charities, with all of the other groups as well, and bringing that together, because the learning is the same, isn't it? And we don't want to be reinventing the wheel all the time.
Waste of resource.
Yeah, it's an interesting thought there to come back to and look out for those spaces to be happening. Some of our listeners are probably new to the world of quality improvement and thinking in this sort of way. Do you have any advice for people starting a project? Maybe people who think they have an idea that there's a problem and they want to think about how to look into it.
If you're someone new into quality improvement and you find that, forget about quality improvement. If you've identified a problem, right? If you've identified a problem, you think there is a problem and this needs to be tackled. Because I keep saying QI is all about, it's a way of thinking. So the first step that you do is talk to the people around you, talk to the team. And this is what we call this as stakeholder engagement within QI, but you simply talk to people around you, try to understand what you see as a problem is actually a problem. Is that what is everyone's view is? I always say this, don't just talk to the people who support your thoughts. Definitely do talk to the people who do not think you're right because they have seen a different view, a different angle that you have not seen. And then QI, the other really important thing that QI says is about starting small. Start small. Start with that one patient, maybe that one clinic, that one paperwork, that one thing. If it works, great. If it doesn't work, fine. Change the process again. And that is what QI is about. A lot of people get put off by the term data, but it is all about that number that you simply collect to say, I've seen 5 patients. It took me 10 minutes to do it my old way. In my new way, I have done it in 5 minutes. Because I've done it in 5 minutes, I have seen an extra patient, or it could be that I finished my admin on time, or it could be that I was able to go finish my work at 5 o'clock rather than staying at 5:30. All that is numbers, all that is data as well. And talk to your local QI team. They will be able to help you. They will be able to simplify things for you. Rather than thinking it is a rigid system and you have to follow every step. Yes, you have to follow the steps, but the more you do it, it will not be a rigid system. You will be able to flow through it much easily than what you think you will be able to do. So just start off, just talk to people to start off with. That, I think that is the key thing.
That's so helpful, isn't it? The basic to talk to people, to get to understand the problem from a range of different perspectives, and then start to plan what you might do. So it's Pulmonary Rehab Week as this podcast episode goes live. What do you think we should be celebrating in the world of pulmonary rehab? There's a lot of good stuff happening. And what do you see and what are you excited by?
What do we celebrate in this pulmonary rehab week? I think first, I really think about my patients now. They've been absolutely brilliant. All patients across the country, across the globe who are in pulmonary rehabilitation, well done to them. Because it's not easy. They get breathless. There's a lot of fear attached with breathlessness. They break all that. They believe on those physios who run the session, come to us time and time again, and get breathless when they are in that environment exercising, but they trust us because they know that we're going to teach them how to control their breathlessness. So a huge kudos to our patients who are willing to come out and try that. It is the first thing I think we need to talk about. The next people who need to be celebrated are our healthcare assistants. or the pulmonary rehab assistants, whatever job role you are in, I don't know. They are the next star of pulmonary rehabilitation. In fact, a lot of pulmonary rehabilitation service, many physios will agree with me, the HCAs or the pulmonary rehab assistants, they run the show. They take it so well. So the next kudos, we need to celebrate them as well in this. And then there's our physios as well, who work tirelessly trying to provide that quality, safe, effective service to our patients. A lot of pulmonary rehabilitation teams across our country now are going through an accreditation process, which is a huge volume of work. Any accreditation process is not simple. It comes with increased workload, a lot of things to do, but everyone is working towards this to make sure we have a gold standard pulmonary rehabilitation service. So it's a huge kudos to everyone who is working on that service now. What am I really excited about this year? I think it's still in the pipeline, but hopefully we will be going into one of the addiction services in one of our ICB boroughs. We're going to have some stalls there, and we're going to be promoting pulmonary rehabilitation. And there's a lot of work going on Twitter, which I really get excited about reading. A lot of people come up with loads of different creative, innovative ideas as well, which is brilliant. So yeah. So that is all I'm looking forward to.
Oh, brilliant. There's so much there to celebrate, isn't it? And bringing it back to the patients who have to turn up, place their trust in the teams around. It's a whole new process for them, but the benefits can be huge when it goes well and when there is that access there. And it sounds, looking to the future, there's lots of new things to be tried, and lots of optimism, which is really great to hear. Well, thank you ever so much for joining me here today. I've really enjoyed this conversation, and I feel like I've learned such a lot as well.
Thank you so much for the opportunity.